I'm Archana Agarwal. I'm assistant professor in the Department of Pathology and also direct the red blood cell laboratory at the ARUP laboratories. And today I'm going to talk about the diagnostic approach to anemia. And the outline of the talk is I'll talk about the basic hematological parameters and go over some of the parameters which we use commonly in the diagnosis of anemia. We'll also talk about the different types of anemia and their clinical manifestations, and then focus on the relevant diagnostic tests for different types of anemia. The basic hematological laboratory test is which we use for the day-to-day diagnosis of anemia is the complete blood count. And we all are aware of complete blood count, but some of the parameters in the CBC can be confusing. And I'll talk a little bit more about those parameters in detail in my next couple of slides. CBC includes mostly the amount of hemoglobin. It also talks about the characteristics of the red blood cells, the number of red blood cells, size, and different shapes of the red blood cells. It also gives us information about the white blood cells and platelets. White blood cells, the number and information about the platelets help us in broad differential diagnosis of anemia because there are different types of anemia which can also have impact on the white blood cells and platelets, and we'll go over some of those later in our presentation. We look at sometimes we have to look at the peripheral smear manually when some of the parameters of the CBC goes beyond the established parameters, like if we see some atypical or the instrument flags some of the parameters. Instrument is not able to diagnose some of the identify some of the cells, or it's like completely confused. So we need to look at the peripheral smear and make our interpretation manually. Like if there is atypical lymphocytes or if there is a blast, then we need to look at it and come up with a manual differential. So talking a little bit more about the CBC or complete blood count, which is one of the most important parameters in the diagnosis of anemia. These are the most common parameter which we see on a day-to-day basis when we are looking at the CBC. There are some other parameters, but most of the time we don't really use, like platelet volume. You'll see that all the time in the CBC. But for all practical purposes, 99.9% of the time, we don't usually use those parameters in our diagnostic workup. These are the most common parameters which are used: hemoglobin, hematocrit, and red blood cell count. The first three gives us idea about the anemia, what is the amount of anemia or the quantity of anemia. If it's a mild anemia, moderate anemia, or severe anemia. So we can come up with that based upon the red blood cell count, hematocrit, and the hemoglobin. MCV, MCH, and MCHC. So MCV basically tells us about the size of the red blood cell. It's the mean cell volume. And this is one of the most important parameter in our diagnostic workup of anemia, whether it's a microcytic anemia or a macrocytic anemia or a normocytic anemia. MCH and MCHC, these two parameters, although included all the time in the CBC, it's not that useful for our diagnostic workup. Most of the time, MCH and MCHC goes along with MCV. Only rarely in some of the rare anemias, the MCHC or MCH would be different from MCV. And we'll talk about that later in our presentation. Red RDW or red cell distribution width, it gives us idea about the range of the red blood cell size. So if it's normal, the percentage of red blood cell is in the normal, RDW is in the normal range. That means pretty much all the red blood cells are of the similar size. If it's like really high, that tells us that some of the red blood cells are smaller in size, some of them are really larger in size, and some of them are normal. And RDW does help us in some of the diagnostic workup or differential diagnosis of anemia, and we'll discuss that again. As I discussed earlier, white blood cell and platelet count, although it's not directly related to the diagnostic workup of anemia, but there are some, it helps us in the differential diagnosis of anemia. Again, elaborating a little bit more on the red blood cell parameters, how these are measured. Hemoglobin is measured directly as the absorbance of cyanomethemoglobin. And most of these parameters, hemoglobin, RBC count, these are measured directly by the instruments. And flow cytometry is one of the common method to get these parameters. Red blood cell count gives us the direct, it measured directly by the impedance. Hematocrit means it's the ratio of red blood cell to the volume of whole blood, and it's a calculated, most of the time it's calculated, but some of the newer instrument also gives us the hematocrit directly. MCV is the mean height of the voltage. So MCV is basically, it's determined by the histogram of the red blood cell size, and it's actually the mean of the red blood cell size, and red cell distribution width, which is not included here, is the coefficient of variation of the mean of size of the red blood cells. MCH and MCHC, although it's given directly by the newer instruments, it can also be calculated based upon the red blood cell number and the hematocrit. As I said earlier also, MCH and MCHC most of the time tag along with the parameters, tag along with the MCV, and it's not really useful a whole lot in like individually if we are looking at MCH and MCHC. Only rarely we use like MCHC or MCH as like a individual parameter for the diagnostic workup. Definition of anemia. So anemia comes from the Greek word, and it means without blood. It's a manifestation, it's not a disease, of numerous causes, and there are like more than 1,000 different causes of anemia. It's basically a physiological manifestation of a disease, underlying disease. It's the condition where capacity of the blood to transport oxygen to tissues is reduced because of the underlying condition. And it's defined by decreased hemoglobin, RBC count, and hematocrit. And all these three parameters, which are the first three, most of the time the first three parameters in the CBC, we use all these three parameters in our definition of anemia. Sometimes you'll see that only RBC count is decreased. Sometimes hematocrit only might be decreased like as an individual parameter. And it's like if it's one of these three parameters are decreased, we would just call it like a borderline anemia. If we need at least, for our practical purposes, we need at least two different parameters to go down to call it anemia. If it's like only one decrease in hemoglobin, then we'll just call it maybe borderline anemia. We need at least two different parameters. In most of the time, if it's like a clear-cut case of anemia, all these three parameters would be like out of range. Treatment of the anemia depends on discovering the underlying cause. That's the most important way of treat anemia, to basically determine what's the underlying cause and then treat that. So evaluating anemia in the lab, we need basic information, size of the red blood cells, whether it's small, normal, or big, and that's determined by MCV, mean cell volume. We need to look at the microscope, see if there are any atypical cells, like sickle cell is one of the common example. If we are saying sickle cells, that means the patient has sickle cell anemia. Also, we need to look at the platelets and the leukocytes because, as I mentioned earlier, there are a lot of different causes of anemia that not only includes red blood cells but also includes white blood cells and platelets. And that basically leads to pancytopenia, not only anemia, but pancytopenia means decrease in all three parameters, anemia as well as decrease in leukocytes and platelets. Reticulocyte count it gives us idea about the ability of the bone marrow to respond to anemia. And this is, again, we'll discuss that in a little bit more detail when we'll talk about the causes of normocytic anemia, as this becomes really important to know how the bone marrow is functioning. If the bone marrow is involved in certain diseases, like if it's a cancer involving the bone marrow, or if some disease like a myelodysplastic syndrome or some other leukemia or something which is involving the bone marrow, then bone marrow would not be functioning to recover or respond to the anemia. So that gives us an idea about the bone marrow's capacity to respond to anemia, the reticulocyte count. So reticulocyte is basically a precursor of red blood cells. So reticulocyte count, and it's in the peripheral blood circulation, it remains only for like 24 hours and then it develops into a mature red blood cell. So if the number of reticulocyte is really high in the peripheral circulation, it means that the bone marrow is really functioning to respond to the anemia, and it's churning out a lot of these immature red blood cells into the peripheral circulation. So that really helps us in basically defining whether the bone marrow is functioning or not. And that is really important for our, not only for our diagnostic purposes, but also for the treatment purposes. Later on, if the bone marrow is not functioning, then it becomes very difficult for a treating physician to treat that anemia, because that might need either treatment to get rid of either leukemia or cancer from the bone marrow, or bone marrow transplant, things like that. But if the bone marrow is functioning fine, then if we treat the peripheral cause of anemia, then the patient should be fine. So reticulocyte count is one of the really important parameter in basically determining the cause of anemia. And then there are a lot of other evidence of destruction of red blood cells, like elevated lactic dehydrogenase in the bilirubin, which is the breakdown product of red blood cell. So these basically gives us an idea about what's going on with the red blood cells. If the red blood cells are getting destroyed, which is the hemolytic anemia, and that's one of the most common cause for normocytic anemia. And we'll talk about that again in our later discussion. So these are the common parameters we need to start when we are basically working up anemia. What's the size of the red blood cells? What does it look like under the microscope? What's the other parameters doing? How the bone marrow is functioning? And if there is a peripheral destruction of the red blood cell. So a practical approach where we start. The first and the most important thing is to know the size of the red blood cell. And we cannot really, we can try to look at under the microscope and try to gaze, like estimate the size of the red blood cell. So most of the time what happens, like as a hematopathologist, we are trained to basically estimate the size of the red blood cell. So it's usually equal, like it should be somewhat the size of the nucleus of a neutrophil. And if it's smaller than that, then we call it a microcytic, but it's just an estimate. It's a very, very subjective parameter. We, for all practical purposes, we do not rely on our basically eyes or microscope to determine the size of the red blood cell. It can give us some idea, but that's about it. We rely on the instrument, the mean cell volume or the MCV to know the size of the red blood cell. The normal reference range, and the reference range varies from the laboratory to laboratory, but most of the time it's like anywhere from 80 to 98 or 100. So the estimate would be around 80 to 100. But it can vary anywhere from 78 to 95 or 98, something like that. anytime the MCV is lower than the reference range established by the laboratory, we call it a microcytic anemia. So that means the size of the red blood cell is smaller. Micro means small, so that means it's the size of the red blood cells are smaller. And if it's more than 100, we call it a macrocytic anemia. That means the red blood cells are much larger in size. This is the basic definition of the anemia diagnosis. Based upon the size of the red blood cell, so if it's a microcytic anemia, the most common causes of microcytic or smaller size of the red blood cells are these three: iron deficiency, anemia of chronic disease, and thalassemias. These are also the common, not so common, although these are the established causes of microcytic anemia. And hereditary spherocytosis, we do see that quite often. We'll talk about that. But hereditary X-linked sideroblastic anemia and lead poisoning, these are rare, but these all six of them come under the common differential diagnosis or the differential diagnosis of microcytic anemia. The most common would be iron deficiency anemia, and we'll talk about that in a little bit detail. Iron deficiency anemia and thalassemias. Anemia of chronic disease is also a common cause of microcytic anemia, but again, anemia of chronic disease encompasses so many different causes of anemia, underlying diseases. So it kind of becomes sometimes it becomes a little bit difficult to diagnose anemia of chronic disease because it can also manifest as normocytic anemia. So for practical purposes, if we are seeing a case of microcytic anemia, the most common differential which should come to anyone's mind is iron deficiency anemia and thalassemias too, especially based upon the ethnicity of the population. Thalassemia has also become one of the common differential diagnoses, and we'll talk about the ethnicity part later on. So the first thing first, iron deficiency anemia is the most common cause of anemia, microcytic anemia, or anemia worldwide. It's most commonly it happens due to bleeding, but it can also happen in some of the underdeveloped countries. It happens due to nutritional deficiency and is also the commonest cause of anemia worldwide because of the nutritional deficiency. But in the United States, most of the time it's due to bleeding, mostly in the elderly population. Either is GI, gastrointestinal bleeding, or bleeding due to some other cause, or cancer-related colon cancer is one of the common cause leading to bleeding, colon cancer causing bleeding and then developing into iron deficiency anemia. Again, in females, because of the menstrual cycle, bleeding can lead to anemia all the time. Females having cervical cancer or endometrial cancer, these can also lead to bleeding and cause iron deficiency anemia. So any cause, bleeding in the United States is the most common cause of iron deficiency anemia. Iron, some of the iron facts. Body iron, 80% of the functional iron is seen in the form of hemoglobin, myoglobin, which is in the muscle, and cytochromes, which is commonly seen in some of the enzymes. About 20% of the iron is seen in the storage form. So 80% of the functional iron is basically gets circulated on a daily basis, and then about 20% which is in the storage form, it's only used when there is iron deficiency or a sudden need of more iron because of the severe bleeding or some other reason which leads to bleeding and cause severe iron deficiency anemia, like accident or something. Iron, it's absorbed in the small intestine. Duodenum is the most, 90% of the iron would be absorbed from the duodenum. Transferrin is the transporter, iron transporter in the peripheral blood, and majority of the iron in the circulation would be bound to transferrin. So transferrin saturation in normal iron, if the patient is not iron deprived, has a normal percentage of iron, in the peripheral blood circulation, it would be transferrin would bind to the iron. Ferritin is the storage form of iron, which is seen inside the bone marrow or macrophages, spleen or liver. So any places where iron is stored, it's stored in the form of ferritin. Hemosiderin is derived from the ferritin and it's the long-term storage of the iron. It's seen most commonly in the kidney renal tubules. So if we are trying to establish a diagnosis of iron deficiency anemia, the common parameters would be serum iron. So iron studies, low serum iron basically defines iron deficiency anemia, but low serum iron can also be seen in anemia of chronic disorder, which is also one of the commonest cause of microcytic anemia. So if we see a patient or a patient with low serum iron, the most common differential which should come to anyone's mind is iron deficiency anemia and anemia of chronic disorder. However, based on some other parameter, we can narrow down our differential. In iron deficiency anemia, pretty much all the cases of iron deficiency anemia should have low ferritin, which is the storage form of iron and one of the most important parameter to diagnose iron deficiency anemia. So ferritin, as I described in the previous slide, is the storage form of iron. So if there is an iron deficiency anemia, the storage form of iron also goes down. So if a patient has a low serum iron and low ferritin, that means the patient has iron deficiency anemia. In anemia of chronic disorder, we can see low serum iron, but pretty much all the iron, even though serum iron is low in those patients, the storage form of iron is usually either normal or in the higher range. So if we see high ferritin or normal ferritin, it could be anemia of chronic disorder. But low ferritin, for all practical purposes, is diagnostic of iron deficiency anemia. High total serum iron binding capacity, also known as TIBC, it basically gives us an idea about the transferrin saturation or transferrin concentration. So if there is low serum iron, the binding capacity of the transferrin is much higher. So in cases of iron deficiency anemia, the iron binding capacity of the transferrin is much higher. So in combination of all these parameters, it's usually possible to distinguish between iron deficiency anemia and thalassemia and anemia of chronic disorder. Most of the time, 95 or 97, 98% of the time, all these serum markers would be helpful. Once in a while, it becomes important or it's required to do a bone marrow. It's an invasive procedure. It needs local anesthetic, and also it's a painful procedure. So most of the time, physician would try to avoid doing a bone marrow just for the diagnosis of iron deficiency anemia, unless all these parameters are failed, or there are conditions where there could be an overlap of iron deficiency anemia and anemia of chronic disorder. So a patient could have like a chronic disease like rheumatoid arthritis and could also have iron deficiency anemia. So in those patients where there are two or different other factors compounding a diagnosis, it becomes once in a while, it's necessary to do a bone marrow to determine the cause. And for in the bone marrow, in iron deficiency anemia, the bone marrow storage iron should be decreased. So bone marrow storage iron, decreased bone marrow storage iron is the gold standard for the diagnosis of iron deficiency anemia. That's basically, if there is a decrease in bone marrow storage iron, that's diagnostic of iron deficiency anemia. In all the other differential diagnoses like thalassemias or anemia of chronic disorders, either bone marrow iron is normal or increased. So that's like one of the gold standard for the iron deficiency anemia. But most of the time it's not, 95 or 97% of the time it's not really required to do a bone marrow. The other serum markers would be helpful to distinguish between those differential diagnoses. So one of the other common differential for microcytic anemia is thalassemias. In United States, in last 5 or 10 years, because of the migration, it's becoming quite common to see cases of thalassemias, especially in like recent immigrant, it's Southeast Asian population, Mediterranean population. So thalassemias are commonly seen in certain ethnic populations. It's becoming more and more common, and we should always remember to keep that in our differential if we are seeing a case of microcytic hypochromic anemia. And people fail to realize that because we always think that thalassemias are not common in the United States, but we are seeing a lot of cases with thalassemias, especially in recent immigrant population. So we should always remember that microcytic hypochromic anemia is not only caused by iron deficiency anemia or anemia of chronic disorder. Thalassemias are becoming really, really common in this part of the world too. So what is thalassemia? Hemoglobin, as we might remember, is a tetramer with 2 alpha globins, 2 alpha chains, and 2 beta chains. So thalassemias happen when there is imbalance between these alpha and the beta chains. So there are 2 different kinds of thalassemias, alpha thalassemia and beta thalassemias. And based upon the production of alpha chains or beta chains, because both these chains are required, it's a tetramer to form hemoglobin. So if there is a decrease in, let's see, alpha chain, then the beta chains is in relative axis and it doesn't have enough alpha chain to bind to. So always alpha would bind to beta. And if there is a free beta, they don't have anything to bind to, the free circulating beta or free circulating alpha is much more toxic to the red blood cell. So that's why if there is a relative axis of any of these alpha or beta, the relative axis of the other one is basically freely circulating in the blood, and it binds to the red blood cell membrane and causes hemolytic anemia, or basically breaks down the red blood cells. So thalassemia is a quantitative problem. It's due to low production of either alpha or beta globin chains, and it's named for the chain which is decreased or absent. So alpha thalassemia is defined by decreased alpha or absent alpha, and beta thalassemias are defined by decreased or absent beta. There are 2 different signs which we always see in the thalassemia diagnosis, beta plus or beta 0, or alpha plus or alpha 0. Plus means there is some production of that particular chain. It could be either 5% or it could be 45%. So there is a reduction in the production, but still there is some production going on. Like if it's beta plus, means there is a decrease in the production of beta chain, but it's very, unless we know the genetic etiology behind the beta plus thalassemia, it's hard to predict the phenotype. So beta plus could mean that there is a reduction of 10%, or it could also mean that there could be a reduction of 40%. So there's a lot of genetic heterogeneity behind the beta plus, but it basically simply means that there is a reduction in the production of that particular chain. 0 indicates complete absence of production. So if it's a beta 0, that means that beta allele is basically not functioning and not producing any beta chain. So that's the basic definition of thalassemia, plus and 0. Demographics, as I said earlier, also is very, very important for the thalassemia diagnosis. It's very prevalent in certain part of the world, most frequently seen in the Mediterranean population, African, Western and Southeast Asia, India and Burma. One of the interesting point about thalassemia is its distribution to parallels that of the Plasmodium falciparum. Most of the time, thalassemias, sickle cell anemia, sickle cell trait, G6PD, glucose 6 phosphate dehydrogenase deficiency, which we'll talk later in this talk, all these get has the distribution parallels that of the Plasmodium falciparum. And the theory is the patients with thalassemia trait or sickle cell trait, the size of the red blood cells are smaller or atypical or abnormal in these particular traits. So the Plasmodium falciparum or the malaria, the bad form of the malaria, they could not survive that well compared to the normal red blood cells. So that's why these patients who have had some kind of a thalassemic trait or sickle cell trait, they have been selected out over like 10,000 years. So this population has had basically genetic advantage over other population which didn't have these traits like thalassemia trait. So as I said, these patients who had microcytic anemia in thalassemia or sickle cell trait, the red blood cells had sickles, so the Plasmodium falciparum or the malarial parasite could not survive that well. So that's why these patients have been selected out, because these patients could basically sustain these malarial parasite much better than the normal red blood cells. So it's very common to see the distribution goes very well along with the malarial parasite. So distinguishing feature between iron deficiency and thalassemia. As I said earlier, the common differential diagnosis for microcytic anemia is iron deficiency anemia and thalassemia, and also anemia of chronic disorder, which we just talked about. But iron deficiency and thalassemia, there are a lot of parameters which can be similar when we look at the CBC. However, certain parameter can be helpful in the differential diagnosis. In the iron deficiency anemia, the red blood cell count is usually less than 5 or 10 to the power 6 microliters. So usually in cases of iron deficiency anemia, number of red blood cells, because it's a nutritional cause of anemia, the number of red blood cells are usually either normal or in the lower range of normal. However, the red blood cell count in thalassemias is more than or in the higher range of normal. If we look at the reference range in the CBC, that's like one of the common or important parameter when we try to distinguish between iron deficiency and thalassemia, because the MCV can be very similar between both of these. The mean cell volume sometimes can have a lot of overlap. However, in thalassemias, usually the MCV is less than 70. In iron deficiency anemia, it's usually either more than 70 or in the lower range of normal. Red cell distribution width or RDW in iron deficiency anemia is usually more than the normal reference range or in the higher range of normal. In the thalassemia, because it's a genetic disorder, there's nothing to do with the nutrition here. It's a genetically acquired disorder. So once the red blood cell or the DNA has the mutations, is going to remain forever. So the size of the red blood cells basically remain of the same size all the time. So the red cell distribution width basically, which tells us about the range of the size of the red blood cell, is usually normal in cases of thalassemia. So if we can remember these three parameters when we are looking at the CBC, I would say more than in 90 to 95% of the cases, we should be able to make a good estimate about iron deficiency versus thalassemia. Most of the time when we are looking at the iron deficiency anemia, I would see a red blood cell in the lower range of normal or less than normal, MCV around 75 or 76, and red RDW in the range of 17, 18 or something like that. In thalassemias, however, it's not uncommon to see a red blood cell of either normal or higher range of normal and MCV of 65 or 60. So these three parameters in my day-to-day practice, which is really, really helpful in making coming up with a differential between iron deficiency and thalassemia. There could be some overlap in about maybe around 5% of the cases, but majority of the time I would say we can make a good estimate or good guess about what kind of anemia is there. Some of the pediatric hematologists, most of the time pediatric hematologists are the hematologists who are basically taking care of the kid with a thalassemia. They usually use some of the parameters, some of the index basically to come up with the differential between iron deficiency and thalassemia. So it means that Menger index is the one of the commonly used index in the pediatric world. And if the ratio between MCV and red blood cell count is less than 13, it favors thalassemia. For practical purposes, for like day-to-day practice, I really don't use this index or determine the ratio. Basically, this ratio is telling me that in cases of thalassemia, the red blood cell is either normal or in the higher range of normal, and MCV is like in the lower range of normal or much lower compared to the red blood cell. So most of the time it's not really required to go and make that ratio. If we carefully look at the three parameters as I mentioned earlier, RBC, MCV and the RDW, we should be able to make a good calculated guess. But these are some of the commonly used index which we might encounter in our differential diagnosis. Anemia of chronic disease, this is also, as I mentioned earlier, it's like one of the differential, and in the microcytic hypochromic anemia. It can cause mild to moderate anemia due to increased hepcidin, and I'm not going to go over in detail about the hepcidin, which is like the iron, the molecule for the iron transport. And a lot of research going on in basically determining the utility and the mechanism why iron is absorbed much in higher quantity in anemia of chronic disorders like in chronic infections, collagen vascular disease and malignancy. Researchers are still trying to understand why that happens, why in these chronic immune mediated diseases we have higher uptake or storage of iron. So what happens in this, as I mentioned earlier, the storage form of iron is really high, but we cannot really utilize that iron. So the body has a lot of iron in the stored form like in macrophages. So if we look at the bone marrow or spleen, we'll see a lot of stored form of iron, but for some reason the physiology of the iron is messed up so much that we cannot really utilize that stored form of iron. So if we look at the serum iron or the peripheral iron in the blood, that is usually decreased. So that's why anemia of chronic disease come under the differential of iron deficiency anemia, because we will see decreased serum iron in both these conditions, in iron deficiency anemia and as well as in anemia of chronic disease. So the serum iron is decreased, but the storage form of iron for some mechanism is increased, and we are still, the researchers are still trying to understand why that happens. And one of the key molecule is the hepcidin, which is the most important molecule to basically absorb iron from the duodenum or the small intestine. So the hepcidin plays a very key important role in the iron absorption, and that's why in cases of anemia of chronic disease, we see increased storage form of iron, but the entire pathophysiology and the mechanism is still kind of obscure, and researchers are still trying to understand that. So that was about microcytic anemia. I hope I gave you the common parameters and the common diagnostic features which can help us in coming up with a differential of microcytic anemia. So let's talk about macrocytic anemia, which basically means the size of the red blood cells are much bigger. So our reference range is about 80 to 100. Here in macrocytic anemia is usually more than 100. And the pathophysiology behind macrocytic anemia is that there is a problem in the DNA synthesis in the red blood cell. And the most common cause of macrocytic anemia is vitamin B12 deficiency and folate deficiency. Both of these, folate and cobalamin or vitamin B12, are required for the DNA synthesis. So that's why if there is a deficiency of any of these, folate or vitamin B12, it basically causes problem with the DNA synthesis. So as we might recall, DNA synthesis not only happens in the red blood cell precursor, it's not really only important for red blood cell precursors. It's important for all the cells of the human body. So in cases of macrocytic anemia, not only red blood cells or its precursors, means like immature red blood cells, which have DNA, nucleus and have DNA, are affected, but also the leukocytes, the WBCs, and platelets are also affected. So that's why it's in cases of macrocytic anemia, all these three parameters are affected. So not only we see anemia, we also see a decrease in WBC and decrease in platelets. So decrease in WBC is known as leukopenia, and decrease in platelets is known as thrombocytopenia. So we see basically, and if all these three parameters are affected, it's known as pancytopenia. So it's not uncommon to see all these three parameters affected in both these conditions. Deficiency results in megaloblastic anemia. So megalo means really big, and blastic means immature cells. So it leads to, because of the problem with the DNA synthesis, it leads to the cells become much larger in size, and since the DNA is not really forming that well, the nucleus of the red blood cells remain very immature. They do not mature. So that's what basically the definition of megaloblastic anemia. It's due to the impaired DNA replication. Leads to impaired nuclear development because DNA obviously is not formed. So the DNA, the nucleus would remain very immature. However, the cytoplasm of the cell would be mature. So that's what it means by nucleus cytoplasmic asynchrony. So that means the nucleus is basically lagging behind in maturation. The cytoplasm is really matured well, but the nuclei is kind of immature, and it's very commonly seen in megaloblastic anemia or in anemia due to folate or vitamin B12 deficiency. Because the DNA is not really functioning that well, the size of the red blood cell precursor, also known as progenitors, marrow progenitors, are much larger compared to the normal red blood cell precursor. The features, the clinical features or the clinical manifestations of both these disorders are very similar. However, there's one exception. Neurological abnormalities are seen in vitamin B12 deficiency, but not in folate, because in vitamin B12 is also important for generation of the myelin, which is the outer covering of the nervous system or the neurons. So that's why if there is a vitamin B12 deficiency, that the outer covering of the neurons, the myelin, is not formed that well, and that leads to neurological abnormalities in B12 deficiency. However, folate, that doesn't happen in folate, because folate is not really required for the myelin generation. But apart from that neurological abnormalities, majority of the features are similar in both these conditions. So the clinical and laboratory findings, there are a lot of non-specific signs and symptoms of anemia, like fatigue, tiredness, failure to thrive, macrocytic anemia, relatively low reticulocyte count. As I mentioned earlier, reticulocyte count basically reflects the functioning of the bone marrow. Since this is not really a nutritional problem, it basically it affects pretty much all the cells. So that basically leads to low reticulocyte count in the peripheral circulation. One of the important diagnostic feature of macrocytic anemia is hypersegmentation of neutrophils. So because of the dearrangement of the DNA synthesis, the segmentation of neutrophils is not like a normal segmentation, which is about 3 to 4 or 3 to 5 lobes. In cases of macrocytic anemia, the segmentation could be much more than the normal segmentation. And this is one of the earliest findings of macrocytic anemia. So when we are looking at the peripheral blood smear, and we see a patient with increased MCV or macrocytic anemia, we try to find hypersegmented neutrophils. And hypersegmented neutrophils, basically that kind of, it's like it's not the most specific feature for macrocytic anemia, but if we can see a hypersegmented neutrophils, is really helpful for the diagnostic purpose. Mild thrombocytopenia, decrease in platelets, or neutropenia, as I said earlier, it's because DNA synthesis is not only required for the red blood cell precursors, it's also important for platelets and neutropenia. So all the three lineages are affected. Megaloblastic changes in marrow is common. Neurological findings, B12 is only seen in B12 deficiency, like loss of position sense, ataxia, psychomotor retardation, and seizures. So these are commonly seen in vitamin B12 deficiency. This is an example of hypersegmented neutrophils. So here there are at least 7 segments of neutrophils. Usually we see around 3 to 5. Here also, this is a somewhat immature neutrophil, but the segmentation is again very atypical in here. Megaloblastic changes in the precursor of the red blood cell. So it basically shows a giant myelocyte, these two. So it's basically the nuclei. If we look at the nuclei, it is very, very immature. The chromatin is kind of dispersed. However, the cytoplasm is bluish, so that means the cytoplasm is kind of mature, but the nuclei looks very, very immature. So that's like a basic workup of macrocytic anemia. Let's talk about normocytic anemia, which is the most of the anemia in our day-to-day practice would come under normocytic anemia category. Differential diagnosis of normocytic anemia is based upon, we basically, there is a big list of normocytic anemia. So anything which doesn't come under microcytic anemia and macrocytic anemia would come under normocytic anemia. So the list of the normocytic anemia is really huge. So basically we try to put normocytic anemia in two major categories, whether the bone marrow is functioning or not functioning. So that means if the reticulocytes are increased in number, that means the bone marrow is functioning. So the most common causes of increased reticulocytic anemia would be hemolytic anemia or post-hemorrhagic anemia or anemia after bleeding. If we see the reticulocytes are decreased or the percentage of reticulocytes are lower than the normal reference range, there is again a big list of causes which can cause normocytic anemia with decreased reticulocytes. Anemia of chronic disorders can also come under this category. Lot of endocrine disease, liver disease, marrow infiltration, myelodysplastic syndrome, which is like kind of a cancer of the bone marrow precursors. Hypoplastic anemia, that means aplastic anemia, so that means the bone marrow is not functioning, whether it's because of the viral infection or some kind of an insult. So the list for the normocytic anemia with decreased reticulocytes is really huge. So evaluation of normocytic anemia, we try to look at the peripheral smear and come up with the reticulocyte count. And then if the reticulocyte count, as I mentioned earlier, is decreased, then we need to work up for the anemia of all the endocrine disease, renal disease, liver disease. If the reticulocyte counts are increased, that means the red blood cells are destroyed in the peripheral circulation due to various reasons. It could be due to some kind of a viral infection, or it could be some kind of autoantibodies against the red blood cells. So there is again a big list for the causes of hemolytic anemia. Sometimes iron studies might be helpful too to rule out, because some of the iron deficiency anemia can also come under the normocytic anemia, especially the borderline category of iron deficiency anemia. So if the iron parameters are completely low, that really would help to diagnose borderline causes of iron deficiency anemia. If all these parameters fail, then the bone marrow biopsy would be the ultimate diagnostic feature, especially in cases of some of the marrow infiltration anemia and the aplastic anemia. Bone marrow becomes absolutely necessary for that diagnosis. Okay, so hemolytic anemia, as it's a major category for normocytic anemia with increased reticulocytes, basically means the bone marrow is functioning. Again, it can be divided into inherited hemolytic anemia and acquired hemolytic anemia. And I won't have time to go over in detail about all these causes, but I'll basically try to give a basic outline of the causes of these. Inherited hemolytic anemia, the most common causes are membrane defects, hereditary spherocytosis. I'll talk a little bit about hereditary spherocytosis because it's a relatively common disorder. Globin defects like thalassemias or sickle cell anemia can also come under this category, most of the time sickle cell anemia. Metabolic disorder like enzyme deficiency, glucose 6-phosphate deficiency is one of the commonest deficiency of the enzyme which can cause hemolytic anemia. So these are the inherited hemolytic causes of inherited hemolytic anemia. Hereditary spherocytosis is the most common cause of hereditary hemolytic anemia. The red blood cells are smaller in size. They are smaller, microcytic, but they're not like the hemoglobin is normal in there. So they are microcytic spherocytes. Size of the red blood cells are kind of smaller, but the hemoglobin is normal in there. So it's basically it's a smaller red. It's a dense form of red blood cells. They're smaller but very dense. The MCV is more or less kind of normal. Usually MCHC. So this is the one parameter where the MCHC is one disease where MCHC can be helpful. So basically MCHC is usually increased, denoting that the size of the red blood cells are kind of smaller in size. Although the size of the red blood cells are smaller, the hemoglobin concentration is more or less normal. The inheritance pattern of the hereditary spherocytosis in about 75% of the cases is autosomal dominant. It happens, if we look at the genetic etiology, it happens due to mutation in the various structural membrane proteins of the red blood cells, most commonly in the anchorin gene. And majority of them, hereditary spherocytosis, if the diagnosis is made and spleen is removed from the patient, because spleen is the most common site for the destruction of the red blood cells. So because of the smaller size of the red blood cells and the condensed form, because of the spherocytic form of the red blood cells, these red blood cells becomes much more kind of tighter. They're not that flexible compared to the normal red blood cells, so they get destroyed easily in the capillary circulation. And the most common site for that is the spleen. So if we take out the spleen, it pretty much cures these patients. However, there might be some precaution needed, overall precaution after the splenectomy. So they might need treatment or for some of the viral infection or some of the common anemia, but most of the time it's basically, if we take out the spleen, it basically cures hereditary spherocytosis. This is what it looks like, a peripheral blood circulation. So the normal red blood cell would have a nice central pallor in the center. However, if we look at the spherocytes, they are kind of smaller in size compared to the normal red blood cell, but also there is no central pallor. So these are basically condensed red blood cells. So that's why it becomes much more kind of tighter compared to the flexible red blood cells, and they're much more prone to destruction. How do we diagnose HS? We look at the peripheral blood smear, and if we see a lot of spherocytes, that's helpful, although not diagnostic. Osmotic fragility is one of the common sensitive tests for the diagnosis of HS. It basically measures the in vitro lysis of the red blood cells suspended in different solutions of sodium chloride. Spherocytes are characterized by the membrane loss, and they're basically less redundant to withstand the decreasing osmolarity. So they destroy much easier compared to the normal red blood cells. However, spherocytes are not, osmotic fragility test is not specific for the diagnosis of HS. It only basically tells us that the patient has spherocytes. It doesn't tell us anything about the etiology of the spherocytes. So spherocytes can be seen not only in HS, but it can also be seen in certain other conditions like autoimmune hemolytic anemia. Burn patients can also have spherocytes. So osmotic fragility only tells us about the basic, the feature that the patient has spherocytes. It doesn't basically tell us about the etiology of the hereditary spherocytosis. This is what basically the curve for the osmotic fragility looks like. In cases of normal red blood cells, this is compared to the normal red blood cells, the HS patients red blood cell basically gets destroyed easily compared to the normal red blood cells. So normally they would get destroyed at 0.5% saline, but in cases of HS patient, they would destroy it at less than the 0.5%. Flow cytometry is the most sensitive and specific way for the diagnosis of HS, because the dye which we use here, it specifically binds to the red blood cell membrane. So if the flow cytometry is positive, that means that the patient has hereditary spherocytosis. It's almost 97 to 98% specific and quite sensitive too. So this is becoming much more commoner and more kind of used test for the diagnosis of hereditary spherocytosis. G6PD, glucose 6-phosphate deficiency. I'm just going to touch a little bit about this because this is also one of the commonest cause of hemolytic anemia. This particular enzyme catalyzes the initial step in the pentose phosphate pathway, which is required for the energy generation. This is an X-linked disease, so boys or the males are affected, females can be carrier. There are a lot of different variant or mutations have been described. It's commonly seen in African American population, about 35% in the Sardinian population, also seen in Asians. So this is again common in African population and some of the Mediterranean population too. The clinical presentation could be either acute acquired hemolytic anemia. So many of these patients or the patients having particular mutations are more prone to hemolysis or destruction of the red blood cells when they are exposed to certain drugs or certain certain beans or dyes. So there is again a big list of chemicals or dyes or drugs which can precipitate these patients. So these patients basically will have to avoid those certain drugs, like fava beans is one of the common cause of precipitation in Mediterranean population. So if this patient had G6PD deficiency, they will have to avoid. Even sometimes the smell of the fava beans can also precipitate hemolytic anemia. Many of the patients would have basically chronic mild hemolytic anemia all their lives. And the phenotype or the clinical presentation depends upon the underlying mutation in these patients. This is a Heinz body test done in G6PD. It's basically showing us the precipitated denatured hemoglobin here. So if this is a supravital stain, and the patients with G6PD deficiency, because of the nature, because the G6PD, this particular enzyme is deficient, they are more prone to destruction, precipitation of the hemoglobin, and this precipitated form of the hemoglobin can be seen by Heinz bodies, can be seen as Heinz bodies in supravital stain. This is again not specific for G6PD. Any condition where we have destruction of stress leading to denatured hemoglobin would lead to formation of Heinz bodies. But in right clinical scenario and clinical kind of manifestation, if we see Heinz bodies, that becomes kind of very helpful. These are bite cell. This is like as the picture shown here, looks like there has been taken a bite. So what happens when those Heinz bodies, the macrophages or the scavenger cells in the spleen, they would try to take out this precipitated hemoglobin, and the macrophages will take a bite. So this part of the red blood cell would be taken out. After that, it basically looks like that. So there was a Heinz body precipitated hemoglobin. It has been taken out by the macrophages, and that's why it looks like bite cells. So although it's commonly seen in G6PD, but again, it's not diagnostic and not specific for it. But in again, right clinical scenario, it's helpful. Test very briefly for G6PD deficiency. The bedside test is the fluorescent spot test. So these cards have G6P, which is the glucose 6-phosphate, and NADP. It basically detects the generation of NADPH from NADP. So we need to put NADP plus and G6PD on this card. And if the if G6PD is there, then NADPH is generated. And if there is no G6PD, then NADPH would not be generated. However, the caveat is it only detects the severe form of G6PD. So enzyme levels has to be below 30% to be basically these cards to be positive. Enzyme activity assays done in the majority of the big laboratories, it basically depends on the spectrophotometric assay. It tells us about the amount of enzyme present. However, all these non-genetic or non-PCR based kind of test becomes really irrelevant if the patient has been recently transfused, which is very common in cases of G6PD deficiency because these patients would lead to acute like hemolysis. After the transfusion, obviously we won't be looking at the patient's red blood cells, we'll be looking at the transfused red blood cells. So these enzyme activity assay and fluorescent spot test is not that helpful. The PCR based test, mutation testing for PCR becomes important at that point if we are trying to basically make a diagnosis immediately after hemolysis, or it's really helpful in prenatal diagnosis and genetic counseling purposes. It will tell us about the mutation and also the predicted phenotype in those patients. So the hemolytic anemia is, we talked about the inherited form of hemolytic anemia. Now a little bit about the acquired form of hemolytic anemia. Inherited forms, although very interesting, we don't see that commonly. Acquired forms of hemolytic anemia are much more commoner than the inherited forms. Immune mediated, we see commonly in cases of infections. Microangiopathic hemolytic anemia, basically it leads to red blood cell destruction, and we see all these destructed red blood cells under the peripheral smear. It can be associated with infection. So again, there is a big list of hemolytic anemia, acquired forms of hemolytic anemia, and these are the common forms, but again there is a big list of acquired forms. Immune mediated hemolytic anemia, most of the time we might not even know the exact etiology why there is a hemolytic anemia in this some of the patients. It basically leads to premature destruction of red blood cells due to acquired antibodies. And why the patient has particular antibodies, it's not always clear. It could be due to some viral infection, or it could be due to some exposure in the past. So these patients basically have acquired antibodies, and that leads to binding of these antibodies to the red blood cells and destruction of the red blood cells. There are two main tests, basic test, direct Coombs test and indirect Coombs test. In direct Coombs test, we are trying to detect the antibodies which are attached to the surface of the red blood cells. In the indirect Coombs test, we're basically trying to find the antibodies in the unbound form or not really bound to the red blood cells. So these are the basic tests which tells us about the whether autoantibodies are present in the patient's circulation, or if they are present, whether it's in the form of attachment, if they are attached to the red blood cells, or if they are freely circulating in the serum. Microangiopathic hemolytic anemia is characterized by red blood cell fragments in the peripheral blood. So it is also known as cystocytes. Differential, if we are seeing a lot of cystocytes under the peripheral blood, in the peripheral smear, our differential, the most common differential is thrombotic thrombocytopenic purpura. This is again a rare, although it's a rare condition, but it's a really dangerous condition, and is characterized by 5 different parameters. Like the patient also has, not only has anemia, the platelets are also involved. The patient also has renal problems, neurological problems. So there are like 4 or 5 different parameters which define thrombotic thrombocytopenic purpura, and these patients need to be treated as soon as possible. Otherwise, these patients really succumb to the massive hemolysis going on. HUS, hemolytic uremic syndrome, happens basically due to some of the toxins, some of the bacterial E. coli and Shigella toxins. These are, although again not common, but these patients need to be treated. And then again, the cystocytes or the red blood cell fragments can form in so many different conditions. Many carcinomas, disseminated intravascular coagulation because of the derangement of the coagulant proteins, and some of these are rare causes of cystocytes, malignant hypertension, some of the giant, really big hemangiomas, hemoglobinuria, March hemoglobinuria, and drugs. drugs are one of the common cause of the cystocyte formation. This is what it looks like, the cystocytes or the fragmented red blood cell under the peripheral smear. So these are the normal red blood cells. So these basically cells are fragmented. Angiopathic hemolytic anemia. This I'm just mentioning this because this is a rare phenomena, March hemoglobinuria, but it's like a very interesting phenomena. It happens basically, it's a disorder of transient hemoglobinemia or hemoglobinuria due to forceful contact of the body with hard surface. So although it's not that rare, although it's not that common, it's a very unique phenomena. So sometimes it's seen in marching, like soldiers or marching band, if when there is a contact of the body with a hard surface, and that leads to, no one really understands what is the pathophysiology in this red blood cell destruction, but this is like a unique phenomenon. That's why prolonged marches, competitive running, karate, and all those things, which can lead to, although very rarely. Hemolytic anemia associated with infection. This is again, there's again big list of all different kind of infection which can cause hemolytic process in the red blood cell. Last but not the least is the paroxysmal nocturnal hemoglobinuria. It's again, although it's a rare condition, it's a very unique phenomena. It's characterized by anemia and dark urine at night. So there is a destruction of red blood cells at night. So that's why the name nocturnal comes from. Also leads to formation of venous thrombi, especially in the large blood vessels. It's an acquired clonal disorder, so it's not really a hereditary or genetic cause. The mutation is seen in this pegylated interferon gamma gene, this particular gene, and this particular mutation is associated with paroxysmal nocturnal hemoglobinuria. Because of this particular mutation in this gene, the synthesis of the GPI linked protein, which is the most important protein to link red blood cell membrane. If they are defective, the red blood cell membrane proteins are kind of not linked properly, and they're much more prone to complement mediated lysis. The diagnostic workup of this condition is basically a flow cytometry based test which looks for the GPI linked proteins. Treatment is basically this particular drug. It has been in use for last, I would say, 7-8 years now. This is a monoclonal antibody against the C5, which is the complement factor, and it works pretty good. It's a directed therapy towards the complement C5. One of the other important caveat of this particular condition is about 10 to 20% of this PNH is associated with aplastic anemia, so basically bone marrow failure, and myelodysplastic syndrome, which is again is kind of a clonal disorder of the bone marrow. So anytime if a patient or clinician is suspecting a PNH, they need to look for aplastic anemia and MDS because of the close clinical correlation between these. That's about it. That was in basic nutshell about all these 3 different types of anemia: microcytic anemia, macrocytic anemia, and normocytic anemia. I've tried to basically give basic information about these anemia. Again, anemia is a really big, vast topic, and we can talk about it for like hours. But this is like a basic kind of workup of all the anemia combined, and I hope that's helpful. Thank you very much.